I have a wonderful panel today, very diverse, different regions, different countries. So why are we talking about this issue today? We have today 1 billion people served by healthcare facility with no electricity access or with unreliable electricity supply. The reason why I mention a reliable electricity supply is because not only when you have a reliable electricity, you don't have the medical devices working, but also because 1/3 of the failure in medical devices worldwide is due to low quality electricity. If we consider, and I was in Somalia actually, and the director of the Mogadishu, the Martino Hospital, showed me an anesthesia machine that broke the months before because of low quality electricity. So we have in the issue of no electricity, the issue of unreliable electricity. Even when we have electricity, often rely on diesel generator, and we have a growing issue with the diesel availability price. So there are many issues, but there are also opportunities. Solar energy is an opportunity. It's one many. And the point is, how can we really use the opportunity to accelerate electrification of healthcare facility? I have a really fantastic panel today, but before moving to the panel, we have really a 2 minutes video that we have prepared. And since it is after lunch, maybe you can help wake up, please.
Access to electricity is critical for healthcare facilities. It can make the difference between life and death. Essential healthcare services and medical devices are reliant on an adequate and reliable source of power. Without power, vaccine refrigerators, oxygen concentrators, and fetal heart monitors cannot function. Doctors must treat patients in the dark, and clean water is often not available. But while most large hospitals have access to electricity, many rural clinics of poor communities do not. Hundreds of millions are served by healthcare facilities without electricity, preventing the use of medical devices and hindering the delivery of essential healthcare services. Urgent action is needed to achieve universal health coverage. Renewable energy solutions, for example, can provide healthcare facilities with reliable and cost-effective electricity when they need it most. Such solutions, like off-grid solar systems, do not require a connection to the national grid, can be rapidly deployed and adaptable to a facility's needs. Decentralized renewable energies also dramatically contribute to increase the climate change resilience of healthcare facilities and make them less vulnerable to the impacts of climate change. Electricity access in healthcare facilities will also improve reliability and functionality of medical devices, laboratory testing, general hygiene, prolonged opening hours, communication and records management, patient and staff sense of security and safety, staff morale, and easier recruitment, training, and staff retention. Unless rapid action is taken, the world won't meet its targets under the 2030 Agenda for Sustainable Development and Paris Agreement. To accelerate progress, it's critical the health and energy sectors work together now to improve and protect people's health and well-being. We need to ensure that access to electricity in healthcare facilities is considered a development priority. Dramatically increase investments in electrifying healthcare facilities and supplying them with suitable and efficient medical devices. Provide the necessary human and financial resources. Increase intersectoral cooperation. Facilitate collaboration between public, private, and non-governmental actors. Health and Energy Platform of Action, building connections for better health.
Excellent, thank you. So as I mentioned, we have now a wonderful mix of colleagues. We have Hassan Osman from Somalia, we have Dr. Bim Prasad Sapkoda from Nepal, Juan Carlos Buley Ayala from Peru, Dr. Aruna Baghosh from CCW, Sweta Narajan from the Global Climate and Health Alliance, and Lux Severi from SC4All. Of all these names, Lux Severi is the only name that I'm comfortable, I pronounced well. All of you, please accept my apologies. Now, I would like to start with Hassan from Somalia. Somalia is challenging situation for many reasons. From many point of view, we have the privilege to work with you and with the Ministry of Health, and we have supported a few electrification of healthcare facility, but then you realize it's just a drop in the huge needs of the country. So can you share with us some of the challenges and some of the opportunities also that the country has?
I will use the easiest part of your name. Fancy, thank you so much for allowing me this opportunity to discuss with you about challenges related with electricity supplies in Somalia healthcare facilities. First, Somalia is facing a very significant challenge in its healthcare facility because of inadequate electricity or completely absence for the rural and very vulnerable areas. And this is directly affecting the healthcare profession or the quality of healthcare that the patients receive in Somalia. You find that something happen every day, like mothers are forcing to give birth in very dark rooms because of absence of electricity, and you see that vaccinations or critical vaccines are spoiled because of poor quality of electricity. This is something happen daily that we see in Somalia, across all regions in Somalia. And that is why Somalia now currently is one of the highest mortality rate by 692 child mortality rate per 100,000 of birth, 692. So that's the kind of challenge that we have on the ground in Somalia because of poor quality or totally absence of electricity supplies for healthcare facilities in Somalia.
Thank you. The number that you mentioned, 692, is really shocking. I mean, I'm sure we will have the possibility to come back on this and to discuss a bit more in detail. Now I would like to move from Somalia to the other part of the world, to Nepal. We are very happy to have Dr. Bim with a short presentation on the country. You can use
it. Thank you, Vinci. Thank you, Government of Colombia and WHO for having Nepali delegates here. We are here, 3 colleagues from Nepal, my respected secretary from Federal Ministry of Health and Population, sitting in front of the hall, and Dr. Meghna Dhimal, senior research scientist working at Nepal Health Research Council. With due permission from my respected secretary, I would like to start my brief presentation about what is going on about the electrification in healthcare facilities in Nepal. Just a brief overview about the Nepal, the sandwich between 2 emerging big economies, China and India. Recently, we have initiated the 7 provinces and 753 local level for the decentralized governance mechanism. And I would like to highlight here the challenges that the emerging due to the federalized governance mechanism in 7 provinces and the 753 local levels, the issue of coordination and collaboration in the healthcare service delivery and the healthcare governance as well. That signifies the challenges of the electrification and all other service delivery arrangements in healthcare settings. And not big population size with less than 1% annual growth rate, and the GDP is not so bigger. And I would like to highlight here one point: the air pollution indicator, only 1 PM 2.5, that is 42.81 per microgram per meter cube. That is of the March measurement, the running months measurement. It indicates what is the magnitude or the burden of the air pollution index in Nepal. This is the average that air quality index that we have measured through 27 air quality measurement stations throughout the country. Now let's switch towards the electrification in healthcare facility. The 98% of the total population has access to the electricity. Among them, most of them are connected to the national grid, and very few, 1.3% only, are connected with the solar and the micro hydro. And the key stakeholders for the energy sector in Nepal are Ministry of Water Resource and Irrigation, Nepal Electricity Authority, and Alternative Energy Promotion Centers. Basically, these three are the government entities, I mean the public entities, and they are doing very good responsibilities on their scope of work, and 98% of the population has the access to electricity. While talking about the healthcare facilities on the electrification part, the among 7,000, around 7,000 healthcare facilities, the public healthcare facilities, not the private, 78.1% has the regular supply of electricity, and majority of them are connected to the national electricity grid. And the hospitals are always in priority for the electric power supply, because they used to get the dedicated feeder during the load setting or during the high demand hours also, so that the hospital services could not be disturbed due to the power cut. But still, some of the health facilities, they have 13% of health facilities, they have the solar system. But basically the solar system has been used for the lighting and heating, not the sufficiently capacity to run the heavy equipments in the hospital settings. The rural healthcare facilities are basically connected to the solar, and still some of the health facilities are using the diesel generators for the alternate source of the electricity. And still we have some challenges due to difficult topography and geography. The topography is more mountains and hilly regions, remote and how to reach locations, and the human settlements or the communities are scattered in the different settlements. And these are some of the key challenges that we are facing in terms of the electrification. And we must say the irregular supply of among 22% of the healthcare facilities are not connected to the national grid, and they have the irregular supplies through either solar or other means like diesel generators as an alternate source. And if we talk about the solar plants are being popular in rural and remote settings of the health facilities. Government of Nepal is committed to the COP26, and we are trying to do the low carbon health system. We have just completed the greenhouse gas emission assessment attributable to the health sector, and the recent report has shown that only 4% of the total emission is attributed by the health sector and the greenhouse gas emission. And for the solar plants emission, not only healthcare facilities but also any of the solar plant installations, government is providing the subsidies. And the recently developed draft of NDC 3.0 has targeted the solar as a power backup in almost 40% of the healthcare facilities, that is 2,800 health facilities by 2035. And still we have some issues on the electrification of the healthcare facilities. Like in health sector, the electrification or the fuel or the energy source line items in the budget has not been mentioned in the health sector budget. and the technical competencies for the preventive and corrective maintenance of the solar or the electrification mechanism in healthcare facilities is always neglected, and always we have the priority of the doctors, nurses, laboratory technicians, pharmacists, or the health service providers, but the electricians or the maintenance technicians are not in our priority. And we would like to connect the solar systems or the alternate power backup systems in the healthcare facilities to the national grid, but still we have some issues to connect the solar systems to the national grids. And we would like to conclude with some way forwards. We would prioritize, we would highlight to establish some formal coordination mechanism between energy and health sector, so that the health and energy issues could be discussed in a single sittings, or in as a common problem. And we would like to connect the national grid to the solar panels of the healthcare facilities, so that there could be the energy and economic benefits and the mutual way. And we would try to arrange some dedicated budget lines in the health sector budget, so that we can ensure the sufficient budget is there with us in our control, in health sector control, to arrange to manage the alternate resources of the energy by solar or the other alternate source of electricity. And the competent housekeeping workforce, the electricity or the solar technicians, so that the biomedical technicians and the solar technician could work together, and the electrification would be the reliable, and that there could be the reliable source of the energy, and equipment could be in good conditions, and we can provide the quality health service round the clock, so that the universal health coverage can be ensured. That's all from for this is just for setting the context to accelerate the discussions in this session. Thank you.
Really key point you highlighted, and I noticed that in 2 slides you mentioned one of the key elements that we keep repeating with Maria, and we organized 1 month ago a conference on healthcare facility electrification, WHO and sustainable energy for all, and the operation and maintenance issue was in every session. It's really what we are all struggling with. I guess part of the issue is that the energy people think is an health problem, the health ministry think is an energy problem, and until a few years ago, when we were relying on grid extension, it was energy. Now that we have the opportunity to have solar system in the facility, we are struggling. Sometimes we have the budget for the diesel, but we don't have the budget for the solar system, and I'm sure we will go back to them. One of the points that you mentioned indeed was a coordination between Ministry of Energy and Ministry of Health, which is exactly also one of the points that we are trying to do. We also have the EPA, but also in this panel we have Ministry of Health from Somalia and Nepal, but we also have with Peru a different ministry. And I'm very, very happy to have one with us. So Juan, if you can share with us some of the points that we discussed about the challenges in Peru, but also the point on coordination, how Peru is managing the coordination between different ministries that are involved in this. Over to you. You will speak Spanish, so we will have a translation. Unless you want to speak Italian, then it's fine too.
Good afternoon, everybody. Warm greeting from Peru. Effectively, as Salvatore said, we coordinate among the different ministries. We have a national plan for adaptation to climate change that has allowed to conduct a coordination among different ministries that had kind of similar objectives, but we didn't know what we were doing separately. One of the groups that have been established has been to look at the access to electricity for health centers. The energy sector, very similar to the one in Nepal, with an electricity coverage of 97%. However, this has shown that most of the electrification is in urban areas, not in rural areas. The rural areas is sort of about 85%. There's still a huge gap to cover in rural areas. There are a lot of challenges. There are issues in which are affecting health. I don't work in health. I work in the Ministry of Mines and Energy. We have this very beautiful project where, I mean, it is the Fund of Social Energy Inclusion. This is to provide all Peruvians access to energy, not only electric energy, but also natural gas energy.
Thank you. Muchas gracias, Juan. Um, I would like to go to Sweta now because we had a chat before this session. She's from the again multi sector cooperation. Again, Sweta is from the Global Climate and Health Alliance. They have provided huge support to this conference, great partner. And if you can share with us some of the points based on what you said, and you know, especially the initial point from Hassan from Somalia, I'm sure is something that you want to reflect on.
Yeah.
Please.
Thank you so much, Salvatore. I think before I even go into some of the points that I wanted to make, two caveats. One, I'm a campaigner, so my job is to repeat things. So you will hear me repeat a lot of things that's already been said. And second, my background is in social science, so I also look at change from a social science perspective. And definitely, I mean, we all know that change is not linear. So the benefits of healthcare electrification is definitely in terms of better health access, better services to people. But I think a lot of the change that and benefits that we have documented are the social impacts. But before that, I just want to, like, from a personal reflection, I live in South India in the state of Kerala, which is, I think, one of the best healthcare systems, public health systems in the country. I live in a hilly region, so I have a first-hand experience of how important a decentralized renewable energy access in hospitals are, because the village that I live in, it's landslide prone. It has massive rainfall, monsoons. We brave it every year, and there are 6 or 7 days without power, like massive power outage. And we have the best community health center, extremely well equipped, good health professionals, but because of lack of, it's still connected to the grid, doesn't have decentralized renewable energy access. So there is a window in the period in the whole year when we are not able to access it, despite it's being completely well furnished. And we have to travel 10-15 kilometers to the next health center to get health services. So, I mean, it's a personal experience of seeing the deficiencies and benefits of decentralized, and especially when the extreme weather events are getting more frequent, more severe, we will see this challenge coming up, and the necessity for powering health centers with decentralized renewable energy becomes even more important. Now, looking at the social benefits, and the colleagues and representatives from the country talked about, like, the healthcare benefits. What we have seen, and a lot of my work has been in central India, where healthcare electrification has really been pioneered and has progressed a lot, that the trust that community has in their health facility when it's electrified in the evenings and the night, and how that has translated into benefits for the community. We have seen health facilities that are electrified in the evening becoming safe space for women who are facing domestic violence, children who need shelter. We have seen health facilities that are electrified doubling up as night schools. In events of cyclones and floods, they are safe spaces because they can provide electricity. You can charge your phone, so you have communication access, which is very important when you are dealing with a crisis, and especially extreme climate event. So I would say electrification has truly transformed the way we see health centers. These are not just places that you go to cure your diseases, they're actually spaces of healing. And that's the true meaning of, I would say, a resilient anchors for communities, especially marginalized, vulnerable, distant communities who are being the worst affected when it comes to extreme weather events and climate-induced uncertainties. So I think that part of impact and importance becomes really, really important in making a case for why we need healthcare electrification.
Fantastic, thank you. When you were talking, I was thinking, when we talk about solarization of healthcare facility, we are talking about climate resilience, we are talking about no air pollution, we are talking about no climate emission, we are talking about something that is cost effective, in the long run is less expensive than diesel. We are talking something that give energy autonomy because we don't have to rely on the diesel disruption that we have seen in basically all the countries here. So why we are not there yet? So why we are not getting, especially the difficult question always to you, Dr. Ghosh. So, so why we are not there? It's the perfect combination, right? It's climate, it's health, it's air pollution, it's energy autonomy, it's clean. We have many donors here. And by the way, you mentioned you are a campaigner. From you, we expect a lot on fundraising. So why we are not getting there? I mean, you have been working, Dr. Ghosh, on different sectors, environment, health. You have a long history of multi-sector cooperation. We have all the possible options here. Why we are not get what we need to do really to attract more funding? I mean, we are energy people, and we always saying, Maria always saying, even energy people are health practitioners, right? When we are talking about electrification. How do you see it? What do you think we need to push more?
Thank you, Salvatore, for putting me on the spot and asking me the difficult exam question. I guess my short answer is hidden in exactly how you framed the question, which is you are identifying, or we are identifying in this room, the synergies between health, energy, resilience, gender, uh, but each of these is actually a different ministry. And let's not just blame governments. I would also argue that even philanthropy and donors say, okay, we fund health, and some other will say we fund energy, and so others say we fund gender, right? So I think this is a fundamental challenge we have, is like how do we actually incorporate the systems approach in our thinking? So I want to just expand on my answer by taking a systems approach. So I don't have a presentation, but I hope you can see this map of India on this on my iPad. This is from a report we published just last month at CEW. We've done the first analysis of the vulnerability of healthcare facilities in India to climate change. There are 200,000 plus healthcare facilities. At a district by district level, we've analyzed their vulnerability, and we think that 40% of India's districts, we've got 700 plus districts, 40% of India's districts have very high to high vulnerability of healthcare facilities to extreme climate events. That's floods, droughts, cyclones, and extreme heat. 20% more is moderate. So 60% of those 200,000 plus facilities are vulnerable in some way or the other to a climate crisis. Now, once you understand that this is a countrywide story, and of course Shweta gave a micro example of even a state where you have very good healthcare systems where it gets challenged by the climate shocks. Now what do? That's where the energy story becomes not just an SDG 7 story. Of course, we'll hear from SE for All, but it becomes an enabler for that systems approach. Right? So it's not a healthcare intervention. About a decade ago, we had done some analysis on what it would mean when you have no electricity versus where you have regular electricity in your healthcare facilities, right? So obviously your services, 24/7 services go from 20% to 60%. Where you need deliveries, children being delivered, where a labor room might be available, goes from 44% to over 90%. So this is the delta that energy then allows for in terms of uh, healthcare services. Then we looked about 6, 7 years ago in one state in India, in Chhattisgarh, which was the first to try and uh, solarize a large number of its primary health centers. So, what difference did it make? One example you gave yourself, Salvatore, I think, is the cost. So, we saw that 90% of the solar powered primary health centers were reporting cost savings relative to diesel run gensets, etc., notwithstanding even the air pollution caused by the diesel run gensets. Then we saw that the same, somewhat in line with what Shweta was saying, the solar powered primary health centers were admitting 50% more patients and conducting twice the number of child deliveries in a month compared to the power deficit PHCs. And please remember, this is a very poor state in terms of per capita income. So, just that ability to deliver energy through a clean energy source then has, again, you're enabling that delta. So therefore brings me to my final point. How do we make this happen at scale? And often the challenge we have is we think a solution that works should be scalable. No, we need to think about solutions that work at scale. That's two different things. Solutions that work at scale means you got to then think about the healthcare facility as part of your broader community infrastructure. And repeatedly, we've seen, and not just in India, across the world, Sub Saharan Africa, Southeast Asia, South America, distributed energy is great, but it's great when you have clear offtake, not just from the household, but from what we call productive and community power. Productive power comes in the form of economic activities, food processing, uh, milk chilling, textiles manufacturing, etc. Community power comes from healthcare facilities, education facilities. When these draw that power, your unit economics of distributed energy becomes that much more attractive. The problem of the operations and maintenance becomes much lower because then you're servicing a large number of consumers. So simply my point is to take a systems approach, first understand vulnerability, second understand the delta from no energy to energy, then understand the improved delta from energy from fossil to energy from solar, and then understand that positioning the health center as part of the community infrastructure gives you one of the best bangs for your buck in terms of making distributed energy solutions viable. So do it that way, you get multiple ministries around the table at the same time rather than having parallel feel good conversations that yield no results.
Absolutely, absolutely, and I completely agree. We have started with the Health and Energy Platform for Action, putting together, trying to facilitate the cooperation between energy and health sector. But that's not enough. I liked also what you said about the philanthropies as well, because I mean, all of us have our responsibility: international organization, financial institution, government, but also philanthropies. I think some of the point I was just reading today, there was a press release from the International Renewable Energy Agency. 2024 was a record year for renewable energy installation, more than 500 gigawatt. But then if you see where these are installed, it's not where it needed more. It's not in Africa, it's not in low-income countries, it's not in healthcare facilities. So I think there is also an important component of philanthropy and donors that have to be a bit more flexible and look at investment, not just with the return of investment from an economic point of view, but as health, right? And this is I found your point extremely important also on the productive uses. So look, now over to you to solve the problems. No, one of the key elements, look, that I really would like you to focus on is the famous operation and maintenance. We have seen, we have analyzed, we have published a report together, WHO, for all, World Bank, International Renewable Energy Agency, where we were mentioning some of the models. And some other models are being tested, but we don't have the luxury of time, right? People need electricity, they need it now. We don't have the luxury to wait 3 years if the energy service model is going to work, right? People are dying now. So how do you see, and also as an outcome from the conference, where we have a very interesting but also frustrating conversations?
Thanks, Salvatore. I was just thinking, if we could electrify a clinic for every time the two of us have been on a panel, we'd be halfway there. You know, in sub-Saharan Africa alone, we're looking at, give or take, 100,000 health facilities, add about 50,000 more for the rest of the world. That's the gap, 150,000, give or take. As was mentioned at the start, 1 billion people are affected in their health-seeking behavior by energy poverty in the health facilities that they aim to visit. And we've done a matching study to figure out how much it would cost to bridge the gap, the energy gap in the health sector, and that number is, give or take, $5 billion. It's 4.9 in the report, well, I'll round it up. $5 billion, 1 billion people. So that's $5 per person targeted, which is, if you look at it from a person economics perspective, it is so low, yet here we still are, right? Where like every year, a couple of hundred, maybe a couple of thousand health facilities get electrified. You know, the ones that were electrified 5 years ago, 10 years ago are no longer functioning. The power solutions, like, we're kind of, you know, it's not a steady state. We're always fighting a little bit against the current. That $5 per person, keep that in your head, because I'm going to give you another number, which is 13x, and that is the multiplier that one research study, unfortunately there's only one, and I would love for there to be several that either back up that number or even give us a bigger number. 13x is the multiplier, which is not the return on investment, it's a social return on investment when you power a clinic. And you see that, of course, in, you know, in reduced travel distances for people to seek healthcare. You see that in patient satisfaction, in health worker satisfaction, in the ability of health workers to do their work, in the comfort that patients have when they're in the facility. And then trying to, of course, put some kind of a numerical value against that. 13x, while at the same time we're talking about like only $5 per person needs to be invested. So why are we still here? Technology, nope, easy. It's the easy part. Putting the solar panels on the clinic is the easiest part of everything we're talking about. Financing, bit difficult. You know, we clearly need more funding. We need more funding and financing. We need both, but especially funding, concessional funding. We need grants. We need the philanthropic sector to really step up and say we can close this gap by or before 2030. And then O&M. O&M is the tricky part. It is very easy to put a solar panel on a rooftop. It is very difficult to make sure that the light is still on 3 years from then, 5 years from then, especially 10 years from then. And the reasons for those can be banal, like they can be stupid. It's as simple as like a $3 fuse that stops working. It is, you know, perhaps rodents that shoot through cables, which is the reason why power solutions stop working. So it is because of that. It is because O&M is difficult, because O&M is not free. It is not, it costs money. That is why it is difficult, especially when you look at this from a public sector perspective and a health sector that in most cases, and probably all the countries where we're looking at, is critically underfunded. You know, I was just with the Minister of Health from Sierra Leone on a panel, and he basically said, we have money for salaries. That's what we have nothing else. The entire health expenditure of Sierra Leone, 4% comes from the public sector budget, the rest comes from donors. So if, you know, not to name anyone, a USAID pulls out all of a sudden, then, you know, they're stuck with a massive, massive gap. And that is what we're currently seeing, unfortunately, in the majority of countries. Let me end with a message of hope, and then one that kind of counters that hope. One is, it can be done. 150,000 health facilities globally. we electrify. I come from the access sector, from the electricity access sector. So I'm an energy person here, wonderfully surrounded by health folks. Um, we electrify millions of households annually. So 150,000 facilities, power solutions, absolutely easy from a logistical perspective, from a technological perspective. But it needs to be embedded as a priority in health, in energy, increasingly in climate. And so that is kind of where my worry is that we're now, what, 2-3 years post-pandemic. If we are not able to close this gap on the back of a huge global pandemic where everyone could not stop talking about the need for clean water for wash, or ventilation, which of course requires power, air filtration, vaccines, of course, that require chilling. If we cannot close this gap on the back of a global pandemic, then I really do worry about, like, we may be sitting here 10 years from now where the gap is more or less still the same. And that is just, of course, completely unacceptable. As you said, these facilities needed power yesterday. They won't get it today. So tomorrow is our next best option.
Thanks. Look, although you said you wanted to close with a message of hope, I didn't see so much hope in the final part. That we will make it. It would be unacceptable not to make it. We have all the possible conditions. As you said, the technology is not an issue. There is a robot on Mars moving on solar systems, so I don't take the energy. Before giving again the floor to our panelists, I wanted to also ask if there is someone from the audience, and if there is nobody asking, I will volunteer healthcare without harms, because one of the key elements that was mentioned here was the health impact. It's clear that we are discussing about one part of the equation, right? We are talking about the electricity, but the kilowatt hour, if there are no medical devices, if there are no water, if there is no trained staff, the health impact that we are talking about is not there. So I know that you, sir, are working on medical devices, so I would like to put you on the spot, and please share some thought on the suitability and the needs on medical devices from what you can say. If we can give a microphone, and the other people from the audience, please get ready, otherwise I will ask you. So get ready with the comment. To the gentleman, microphone. And be provocative, and challenge these people on the panel here.
Thank you, Salvatore, and thank you to the panelists. My name is Josh Carliner. I'm Director of Global Partnerships for Healthcare Without Harm, and we are an international NGO that works on sustainability issues in the healthcare sector. Arunava talked about the need to have a systems approach, and that's absolutely right. And you were talking about it in the context of sort of a cross-sectoral systems approach, but I think to sort of narrow that down a little bit within the healthcare sector itself, when we're talking about these issues, we need to take a systems approach. And Salvatore was referring to that a little bit. First of all, I think, when we think about solarization of health facilities, we need to think about it as solarization for climate resilience and community resilience, which means both adaptation and mitigation. Some of the panelists talked about the importance, I think Shweta talked about the importance of having a reliable energy source as a form of disaster preparedness, which is a climate resilience and adaptation strategy. And it's also a low carbon and ultimately net zero emissions strategy, which meets sort of a part of what Nepal signed up to as well with the COP26 health program and its commitments both on adaptation and climate resilience. And then part of that systems approach, I think, also needs to, anybody, if you start looking at solar, and you guys are all experts up there on this, and so you know this, you can't just slap solar panels on the roof of a facility. You need to make sure that the facility itself and the building itself is as energy efficient as possible. And then ideally, you make sure that the devices that are being used in that facility are as energy efficient as possible as well. Otherwise, you're, in a sense, wasting energy that becomes not economically viable and often not technically viable, given the roof space you have for the solar often and the needs of the facility itself. And so, sometimes it's as simple as you just need light to be able to have basic basic light for mother to give birth. But then if you have some of the other devices that were shown in that video, you're going to need to have as efficient devices as possible and as efficient a building as possible in order to make it work. And then operations and maintenance were another part of this, the systems approach that were mentioned, which are key, right? Because of the problems that Luke was just talking about. You end up with the classic development problem of a development project, 5 years later with the waste next to the facility and not being used. And we don't want that to be what what we're doing here. And training goes with that, maintaining the cold chain goes with that, and having using renewable energy for that. So it becomes a question also of production, sort of innovation, production, manufacturing, distribution, and then implementation. It's a whole supply chain question that it turns into. And so I think, all of that needs to be taken into account as we think about this. And the end product is a well-lit, well-functioning facility. So that would be my small contribution to this conversation. Thank you very much, Salvatore.
Thank you, and indeed an important conversation because, as you mentioned, also from an economic point of view, if you have an energy efficient devices, you need less energy and therefore smaller solar system, and therefore again lower cost. So I would say, in addition to energy efficient, suitable for harsh conditions. What we have seen in medical devices often are very sophisticated. They require a lot of maintenance, while they have to be simple, low maintenance, robust, and suitable for air condition. We have another question, and then I saw that Sweta and Arunabha wanted to also get
just
back.
One other point on that is that they need to be increasingly climate resilient.
Absolutely,
Devices
like everything that
in
we have.
extreme heat situations, we need to be changing what we're manufacturing and how we're
Absolutely,
manufacturing it.
absolutely.
So it withstands climate conditions.
Thank you, Helen. The microphone.
Hi, I'm Elaine Fletcher. I'm the editor-in-chief of Health Policy Watch, but I was with this team and was participating in some of the early work on health sector electrification a decade ago. And I've been a big fan, to do the quickest thing, the fastest from the beginning. So I really admire Salvatore's approach in terms of trying to electrify health facilities. But I think what Aruba said, as I've come along and learned more about this, if you really, especially with O&M issues, if you draw on the productive sectors and really have a community-wide approach, then you're going to have an investment that's so big nobody's going to neglect it. And this does involve, it's more complex and involves the energy sector. And the question is, how to crack that nut. And what struck me last time I did a story on this in October at the World Health Summit, there was a discussion. I looked at the Green Climate Fund data. I can send you all the link, but I found there's only been 4 projects for renewable energy approved in Africa since the fund was created, or 5 maybe. And several of those are really more like upstream kind of searching projects, or they're not really concrete putting stuff into the ground or wires in the walls. And the health sector facility, the first health sector facility resilience project that was supported by the Green Fund, which got a lot of positive attention in Malawi just recently, has no electrification element. So what strikes me is, and finally I will add, I've got a pretty close friend who's a solar power developer in the 5 megawatt to 80 megawatt range, I would say, and has had several successful projects in Africa, including a prize-winning project from the Nordic Fund. He's got 10 projects on hold, all in Africa, and can't get what he calls the $2 or $3 million for development funding from the World Bank or a multilateral bank to create do the engineering plans and get the permits. He says once he does that, he can get commercial loans, and once he has a shovel-ready project, he can go in and do the project. And I know one of them, I give an example, is Juba, South Sudan. The whole town runs on diesel, and he has been waiting for like 5 years. He's got other projects in Ethiopia and all sorts of other places. So I did sort of become a convert to the bigger approach, which integrates also then better with the grid in the end and all this other stuff. But the finance just isn't there. And if you look at the data on investment in renewables, it's happening in more middle income countries from what I recall, you know, the Philippines, but it's not happening in Africa. Unless, you know, with Nepal and India, I think there's a more mixed bag. But that's, to me, the scream and cry that needs to come out now from the health sector is to the development banks, to the World Bank, and the others. Why aren't you financing renewables in Africa?
Thanks. I guess
That's a comment, not a
no, but it's a very important comment, and indeed. We often hear, and the COP is a typical example when we hear these multi-billions commitment, right? From mythological billions that are being committed for the sector. But then when you go into the detail, it's super difficult to access. You require 2 years of applications, or it's concessional loan, while an healthcare facility in rural Somalia doesn't need a concessional loan, they need grant. And that's the reality. We are not talking about sustainable or economically viable instrument. We are talking about human right. And unfortunately, it seems that's not enough, including from donor for energy and climate, to choose healthcare facilities as a priority. And all of us have a responsibility on this. So it's a very important comment. So as promised, Sweta and then Anurama. Thank you.
I really appreciate Anuraba mentioning the systems approach, because I think that's core to everything that we're talking about. But I also feel like and I've often, it's struck me that there's such a huge burden on the health community to deal with everything that is happening, from like shortage of staff to escalating crises and responding to it, and always the expectation is that the health community has to be there despite, I mean, irrespective of whatever challenges they're facing. And in that, I feel we're constantly firefighting, and we're not getting ahead in kind of planning, because I am a complete, full support for healthcare electrification, but if we don't have the systems lens to it, then I've also heard stories from health centers that were not electrified and now are fully electrified, where caregivers have said that when we bring pregnant women to the facility, earlier we used to bring like 2 candles because there was no electricity. Now we've been asked to bring 2 buckets of water because there's no water. So the healthcare facilities are lit, but because we have not made the intervention in a holistic systems, and vulnerability assessments have not been done, and we are not planning, because we are kind of dealing with one problem at a time, where the need is to kind of concurrently deal with the challenges and think ahead and plan and be prepared for or with a health systems that is fit for purpose in this changing scenario. And the second thing I want to caution is that once a template works in electrification, my caution is that unless there is community participation to give it the shape and feel in that specific in different geographies, caution is against using the same template for even in certain places in India or similar geographies, because again, this is a story from Chhattisgarh, where people appreciated health facilities being electrified, but they were still not using it because the access to health facilities were not electrified and there was danger of snake bites. So community participation helps decide where to prioritize within the health system, in low resources, what to prioritize to increase access and increase services. So community part, not kind of one size fits all, and a systems holistic approach is absolutely essential. And I don't know how we're going to do it, but we must do it.
No, absolutely, you are right. Aruna, I would like you, Aruna, also to comment on this part, because Sweta mentioned the point on water, and indeed, I mentioned before 1 billion people served by healthcare facility with no electricity or unreliable electricity. At the same time, 850 million people served by healthcare facility with no water, which is even worse. Often we are talking about the same facilities. So when we're going there and we say, we do an assessment for healthcare facility, we see no water, no medical devices, no trained staff. So absolutely, completely agree with you. No electrification, as Maria often say, no healthcare facility if there is no water and electricity. On this, Anwar, if you can also comment on this aspect, on the coordination between energy and water, in addition to what you wanted to say before. A special thank to Anuraba because he didn't have lunch. He's going from one session to another session. We're keeping him very busy. So please go ahead.
No, I think the gentleman here had a question. Should we take that and then I am happy to answer
Okay,
his
thank
views.
you.
Sorry, I
Thank you.
didn't see you. Please.
Thank you. What I want to share it was about what Shweta has said last. She mentioned it. We shouldn't ignore about the community contribution. For example, I came from Eritrea. As you all know, Eritrea is a small country, small resource, but we use the resource wisely. Community contribution, for example, especially the school, in schools and health facilities, community ownership is very important. So we emphasize Eritrea, the Minister of Health emphasize or stress the ownership of the health facility to the community. So the community contributes. If you make the community understand the problem, the challenge, community has big role. For example, in Eritrea, there are health facilities who are supplied with solar power by the community. There are schools who are supplied with solar power by the community contribution. There are the ambulances, for example, if they get some spare parts challenge or shortages, community buys the spare parts. So community contribution is very important. So we should make the community as part of our stakeholders. The big question with solar power is maybe it might not be relevant. The e-waste, the waste that is generated from the solar power. We should think about this. It's really, really big problem in our country. For example, we are having many batteries. What are we going to do with those batteries? So this is what I want to share. So the data, how many health facilities are supplied with solar power in Eritrea? We are 100% of our health facilities, especially the community-based primary health facilities, are supplied with solar power. Why? Because of the community contribution, plus the government emphasize health and education as number one priority, social justice, because it's social justice. Thank you.
Thank you. Very important point, and especially the part on e-waste. I would say this is not only for the healthcare facility electrification. This is an issue that we are having in electrification in general, because with the decreasing cost of solar and battery, we will have an immense deployment of decentralized solar system, and the e-waste is something that we need to address collectively, not only as a health sector, but as countries, because it will include education, private sector, public institutions. So we will need to manage with management disposal, especially the batteries. So Anurag, over to you, but then all of you, if you want to think about one single comment before we close the session.
Yeah, first of all, thank you for very rich interventions. They're all very thoughtful, and we shouldn't assume that we all have immediate answers. I think humility is a good virtue to have in public policy. Nevertheless, I want to make 3 points, and building up from, first of all, the challenges of the health sector itself. So I think the example that was just given, I think it was Josh who was saying it, or maybe it was Luke who was saying it, right? If you have a health ministry that is so underfunded that you're barely able to cover staff costs, right? If you have some money left for capital expenses, where would you put the capital expense? You would probably put it on building one more primary health center rather than you putting it on the energy of the existing primary health center. That's what a health ministry will do. If you have a little bit more money, you'll probably put it towards installing some equipment or medicines in that primary health center rather than the energy side. So what I'm trying to say here is, we are not going to solve this problem, Salvatore, by putting all of the burden on ministries of health and departments of health. Go figure out how to train your doctors, then go figure out how to build a PHC, then go figure out how to put in equipment in that PHC, or also go figure out how to electrify or give water to the PHC. This is not a formula for success. Of course, not for a poor country, but even in a rich country, you're not going to get that. So, one uh, suggestion I would make, and I'm not suggesting that it'll work everywhere, but to deal with both the capex problem and the O&M problem, think about electrification of public health facilities as a service rather than as a capex. Right? So then what happens is you're actually amortizing the cost of, say, providing reliable energy services, at least for, say, 8-9 hours a day, and keeping, say, the emergency room going 24/7 over a 10-year period. And that forces the energy developer to incorporate the cost of O&M into the offering. But I can argue from so many other experiments we've run on electrification, on clean transportation, etc. You do a reverse auction of that, aggregate all your primary health centers, etc., and then say, okay, for say, not maybe not 150,000, but even for 1,000 primary health centers together in, say, a few countries in Southern Africa, let's say, what would be the reverse auction revealed bid price for energy as a service that provides this reliable power? I think this would significantly reduce the capex obligation on departments of health. My second point is that when you link to Shweta's point about water as well, I served until recently on something called the Global Commission on the Economics of Water. And my next book is going to be on water. One of the missions we have put forward in that Global Commission is that we have to ensure that no child dies from unsafe water by 2030. Now, in order to do that, it's not just the piped water or otherwise at the household level, it is actually the water that is available in health centers. Again, if you treated water not as just a capex of the pipe, but water as a service, and then leveraged the community participation to enhance the circular economy of water, the retreatment of the water, and even the payment for water. We understand water is a human right at a basic level, but what it does is it distorts the water pricing in such a way that rich people like us get water at almost no cost, as the poor who are paying several dollars for just a few liters of water. So changing that again, so now you integrate capex, the water as a service and energy as a service for primary health centers. My final point is about financing. My country has become the fourth largest renewable energy market in the world by deployed capacity, 220,000 megawatts of non-fossil electricity capacity, and it gets only 3% of clean energy investment. All of sub-Saharan Africa gets less than 3% of clean energy and global clean energy investment. Money does not flow to where the sun shines the most. The reason it doesn't is because our risk perceptions are completely distorted. The perception that if I invested in a clean energy project in Malawi or in Kenya, I will not get money back, so may as well invest it in New York. Now, there is risk, of course, in investing in a developing country, emerging market. But there is the delta between the real risk and the perceived risk is not as high as what we perceive it to be. That reducing that information barrier and forcing multilateral development banks to stop doing just project financing and instead doing risk mitigation of investing in these critical infrastructure, as well as providing grants where it's necessary, is a change not just in the mission, but in the operation of how multilateral development banks work. If you're going to give your incentive structure to only how many loans you can give out, you're never going to solve the system-wide problem of lower cost finance for critical infrastructure in developing economies.
Thank you, thank you. Please, colleague, look, a final comment and then from all of you, please, colleagues.
final comment. Let's see. I just want to pick up on the energy as a service because you mentioned it, so or you just mentioned it as well here. Energy as we talk about energy as a service maybe too often. We at SCPRO are very guilty about that, trying to position it as the thing that will save us all, the thing that the golden key to address O&M. What we need to be more cautious about is that when we talk about energy as a service, that it is not misinterpreted as this has to be a for-profit model. When we talk about energy as a service, talk about a service provider who provides a service, an energy service, making sure that the power flows to a health facility, making sure that if something breaks that it is fixed, and they get remunerated for that. That does not mean that it's a for-profit model. It just means that there is an agency that has some skin in the game, that has a reward to make sure that what we want to see happen, which is the power solution works in year 1, 2, 3, 4, and all the way up to year 10, 15, 20, that somebody has something to gain and potentially something to lose if it doesn't happen. Again, that does not mean that we want the rural health facility in Malawi to be more financially sustainable than one just outside of London. That is lunacy. But I feel like that's often where some agencies or some of this thinking around energy as a service is like, what can the health facility pay? And that's the only thing it will provide. No, I mean, clearly that's not a way to think about human health, about a human right. The reason why we talk so much about service and service providers is because we feel it is a way, not the only way, but it is a way, especially in countries where public sector capacity is limited, it is a way to ensure that we at least improve the impact of the investment that we're making on the power solutions. And I'll end with this because it's always good to keep things light a little bit. I worry sometimes when these huge projects are being deployed and say, and now we're going to train the health workers to manage this gigantic solar farm, which I'm like, why would you train nurses and doctors to become electricians? Of course, training electricians to become nurses and doctors is worse. Nobody wants that. But let's make sure that we try to crowd in the actors that have the right skills, the right incentives to carry out a particular piece of this much larger value chain. The last thing I do want to say is, you're right. We talk a lot about supply being solar panels, batteries, and cables. We don't often talk about, as Josh mentioned, about appliances, about the demand side. You mentioned, a health facility without power or water is not a health facility. The same can be said if there is no staff, if the patients don't show up, if the pathway to get, if the ambulance doesn't work. Clearly, it's a very, very long pathway. So I'll end with these semi-wise words. Electricity is necessary, but not sufficient.
Absolutely, only part of the question, and I'm happy that you highlighted the role of private sector. Look, obviously, when we talk about the involvement of private sector, of course they have to be involved in the installation part, in the operation and maintenance. Even in Somalia, we found a company from Somalia who worked on the installation part, on the operation. And we have to avoid this misunderstanding of having a private sector-led enterprise. This is the public sector has to be the responsibility to drive this. Comment from Juan from Peru.
Okay, gracias. Okay, thank you. An important point that you've touched upon is maintenance and the sustainability over time. In Peru, the facilities have been managed by private companies with funds from a cross-subsidy. It is worth saying that the biggest energy consumers, both in terms of electrical power and hydrocarbons, provide some support, and that energy social inclusion fund that is not only used for photovoltaic connections, but also the massification of gas and the replacement of biomass for generation of food, actually allows us to filling this gap. The Peruvian government has installed a lot of photovoltaic facilities when the technology started out, but over time they became obsolete because of what the gentleman from Eritrea was saying in terms of what we can do with the batteries, because at that time the technology was still in its infancy. And what do we do about cables? What do we do with people if probably we had to train people in communities? And that, in some way, in Peru, we've tried to use the concession model, which in reality um, is being utilized by state companies or private companies to ensure sustainability. And there is an issue that I would like to address with regards to the fact that it's not only power and healthcare, but it's also a more global issue related to the use of water. Thank you.
Over to you, please.
To conclude, I would like to emphasize on one aspect that has not been discussed yet here. That's about the perspective of the healthcare service providers. If the healthcare facility is electrified, then how the healthcare providers safe feel safe to provide the healthcare services around the clock, even in the evening and the midnight. One aspect, and in Nepalese context, we have found that the retention of health workers in a rural location, if the electricity is there in healthcare facility, in hospital, or a basic health service center, rural location, the nurses or the doctors, the young medical graduates, the tendency of retention in that location is higher, significantly higher. And that's why that is also the good impact on the health service providers perspective. And the next perspective that I would like to emphasize here is, let's make this
Electricity access, you see?
let's make the electrification or the energy provisions as an essential component of health infrastructure design. Let's think about the design and the maintenance, not only the maintenance, design and construction of the hospital buildings and the healthcare facilities, the wash facilities or the electricity facility. Let's think as a single project or a single approach of designing the healthcare facilities infrastructure. Just building, construction of building, or hiring some health workers or doctors, or putting some basic equipments. That is not only the health infrastructure. The health infrastructure, let's think about a single design or single unit, including the electricity or the reliable source of the energy, as well as the physical infrastructure. If we can think as a single, the single project or the single unit of building and energy as a one unit of the infrastructure, then it could be a solution for our context in lower middle income countries. That's all.
Absolutely. Thank you. Hassan, final comment.
Yes. Thank you, Fancy.
Please.
Depending on diesel is very expensive. But imagine with me that when you have recurring flood and drought in your region, and especially like where I come from, Somalia, where we receive every year once or twice by flood, and plus of that, having conflicts that sometimes damage energy supply to some areas. Plus to that, poor infrastructure. And all of these, that is what makes us the most cost energy countries in Somalia, is one of them Somalia. Therefore, I believe that this is not, and when you see the perception of healthcare facilities establishment, there is no any single thing that planning that climate hazard can come anytime. Therefore, I believe that we need to consider something that address this complexity, like making very holistic resilience, because even the resilience has become very dramatically very poor to us. The healthcare facilities cannot even withstand a very short rain or maybe flood or climate variability because of this standing issue. Therefore, I believe that we need to make a good, very strong plan that integrates climate and all aspects of climate shocks and making climate resilience health system.
Thank you. We are at the conclusion of the session. I would like just to since there is Maria there, our director, I would like her to have some closing remark. But before doing, let me thank the interpreter. We talk very fast, especially me as in Italian, so sorry, thank you. And the IT team and my colleague Aubrey, who has been supporting us. And all of you really amazing. Please, a round of applause. Really fantastic team. And Maria, over to you.
Thank you very much, Salvatore. Thank you, all the panelists. I hope you're not sacrificing lunch. Did you have lunch? Of course you didn't. Anyway, thank you, because this is energy as well. And we want you with full of energy, healthy and fresh and renewable energy. Salvatore asked me to say a few words. I don't know what else to say. Let me just a couple of reflections. It's clear, very clear, it was very clear for me a long time ago that energy and health and energy needs to work together. I mean, no health without access to clean sources of energy for air pollution and for many other reasons, because we need it at the healthcare facilities, because we need to tackle the problem caused by climate change. So clearly, health and energy sectors now, we need to work, we need to be very creative, and we need to use the health argument to maybe push this agenda and advance a little bit. So clearly, we need to energize the healthcare facilities. And the second reflection is about how much you, a specialist on energy, you need to look at how much responsibility you have as well and opportunities on contributing to the health achievements that we want, all of us. So you are ministers of health, as Salvatore was referring. You need to be conscious that whatever you are doing is not just about energy, is about health. You are ministers of health as well. Remember that, Luke, we were together on a panel some years ago, many panels as well, but one panel some years ago where people was asking me all the time, from WHO point of view, from the health point of view, what are the different studies, scientific evidence proving that it's important to have access to electricity in the hospitals? I say, why do I need to prove that? I refuse to prove that. You have to prove me the contrary, that not having it is good for health. I refuse to do that. So please, let's put our healthcare facilities on a dignified way again. So if you don't have water, sanitation, soap to wash your hands, and electricity, call it something else, but don't call it healthcare facility. Call it a place where you go, and if you are lucky, you might get an aspirin or a paracetamol or a good advice. But if you don't have the minimum services, don't call it a healthcare facility. So let's together dignify again the name of a healthcare facility, provided all of these services. You were referring, Luke, to the fact that in Sierra Leone, they spend very, very little on the health system. But you know, the funny thing is that they spend a lot on buying diesel for diesel generators. So we need to bring the common sense. Oh, maybe you know, common sense these days have another meaning, but on the meaning of the good advice, let's make sure that all of these basic things doesn't need to be justified. Of course, we will have plenty of challenges, batteries, maintenance, prices, whatever, the lack of capacity. But I think now we are very solid together, and this cannot change. We need to scale up no matter what, with all the consideration, your incredible expertise, because you have the expertise, I don't. That's why we have an engineer now. But what I can tell you is that we need electricity at the healthcare facilities. So do whatever is needed, but bring us electricity to the healthcare facilities. WHO is extremely committed to that. Thank you so much. Thank you, Salvatore, for putting me on the spot.